Good evening, everyone, and welcome. This VGR is supported by Sanofi Regeneron. We would like to thank Sanofi Regeneron for their generous support of this evening's presentation. Next slide. Welcome to the ACG Virtual Grand Rounds. We're thrilled to have so many of you join us live for the presentation this evening. I'm Jacqueline Gollin, and I'm the founder of Gastro Girl and GIOnDEMAND. I will be the moderator for the question and answer period that will follow the presentation. All attendees will remain in listen-only mode. If you have any questions, please type them in the question box. We will try to answer as many questions as time will allow following the presentation. A handout with the slides and room to take notes can be downloaded from your control panel. Handouts with larger slides will be posted to the Virtual Grand Rounds page tomorrow. Next. I'm so excited to introduce our two amazing speakers for today's Grand Rounds. First, we will hear from Dr. Crystal Lynch. Dr. Lynch is an associate professor of clinical medicine and director of the GI Physiology Laboratory and director of the Advanced Esophageal Fellowship in the Division of Gastroenterology at the University of Pennsylvania. Next. Then we will hear from Dr. Amanda Muir. Dr. Muir is an assistant professor of pediatrics and co-director of the Gastrointestinal Epithelial Modeling Program and associate director of fellowship research in the Division of Gastroenterology, Hepatology, and Nutrition at the Perelman School of Medicine at the University of Pennsylvania. Dr. Lynch, I will now hand this over to you.
Hello, good evening, everyone, and thank you to the ACG for inviting us to speak today. Today we will be talking on eosinophilic esophagitis. As you know, this is a chronic immune-mediated allergic condition characterized by eosinophilic infiltration of the esophagus. Here's a schematic of the basic pathophysiology of EoE. We know that environmental factors interact with the patient's diet, microbe, and the esophageal epithelium, leading to a cascade of multiple effects, including multiple pathways, such as the Th2 pathway, including IL-4, IL-13, and IL-5. Eventually, as you can see here, this leads to downstream effects, including remodeling, loss of barrier function, as well as eosinophilic inflammation. Today, we're going to talk about various aspects of EoE, including epidemiology, full pathophysiology, presentation, as well as therapeutic options. We'll start with epidemiology. So EoE, is this a rare disease? You know, I have this case series here that you can see. It says esophageal eosinophilia with dysphagia. This is like a new, distinct clinico-pathologic syndrome. And you can see that this is actually from 1993. So this is describing patients who didn't have classic symptoms of GERD, but were found to have eosinophils in the esophagus. And it's very interesting to note that this was published in 1993, not that long ago. EoE really not that long ago was considered a rare disease. But looking now, we can see that the incidence and prevalence have increased significantly over time. You can see the incidence trends in A at the top and the prevalence trends in B at the bottom. And as it gets more and more towards our current state, you can see that the prevalence in most locations have increased. The overall prevalence estimate currently is 0.5 to 1 cases per 1,000 persons. EoE is a global disease. This is looking at a map of the world here. You can see in Western Europe, United States, Australia, the prevalence rates are much different and higher than in Asia. Next, we'll talk a bit about the pathophysiology of EoE.
So as you can see here, these are two esophagi that have EoE, and these esophagi have distinct markings related to EoE, specifically friability of the mucosa. So the esophageal mucosa should look like the inside of your cheek. It should be pink and soft. And as you can see, just having the scope within the esophagus is causing there to be some bleeding. And then we have what's referred to as rings or trachealization. And this is when the esophagus gets stiffer and there can be these areas of narrowing. As you can see on this esophagus over here on the right, there's actually luminal narrowing of the esophagus. And then lastly, we see some of these white plaques within the esophagus, and these are actually little collections of eosinophils if you looked at them microscopically. And so all of these things are what we see when we do our endoscopies as gastroenterologists. And this is what eosinophilic esophagitis looks like under the microscope. And instead of having a nice differentiated squamous epithelium, you can see there's increased cellularity. All of these cells are infiltrating the esophageal epithelium. And then these hot pink cells here are the eosinophils we see. And so these cells degranulate and then cause damage in the epithelium, resulting in the endoscopy findings we just saw. So I know Dr. Lynch just went through the exact molecular mechanisms of IL-4, IL-13, IL-5. All of these cytokines are released by T cells, and they cause a tremendous amount of damage. And so kind of boiling that down to what is actually happening in the esophageal epithelium in eosinophilic esophagitis. And as you can see in homeostasis, the esophageal epithelium has a differentiated layer of squamous epithelium, and underneath there's connective tissue and fibroblasts. However, in the setting of eosinophilic esophagitis, exposure to common foods like milk, wheat, or even some environmental allergies like pollen lead to a tremendous inflammation in the esophageal epithelium and damage. You can see that there are spaces in the epithelium that allow for particles to migrate through. There's eosinophil infiltrate as well as T cells. And here in the underlying lamina propria, there's activation of the fibroblasts, and that leads to stiffness. So the hallmarks of eosinophilic esophagitis are really an immune infiltrate, a mixed immune infiltrate, epithelial damage, so the lining is really damaged, and then underneath there's stiffening. And so the thing that causes the most side effects of EoE is fibrosis. And fibrosis is really just a narrowing of the esophagus in the response to excess collagen deposition. So as the inflammation is happening in the esophagus, it's leading the cells and the fibroblasts to secrete collagen. This collagen leads to stiffness, and it gets stiffer and stiffer and stiffer over time. And one of the reasons we really need to treat is that over time, the esophagus gets more and more narrow, leaving patients with more and more dysphagia or trouble swallowing, and they're at higher risk of food impaction and higher risk of needing to have an esophageal dilation. And I always think this is an interesting study done by Schupfer et al. Back in 2013. And what this group did was they said to patients, as when they got diagnosed with EoE, how long have you felt like you had symptoms? And the longer they said, the more likely they were to have strictures. And I think what this signifies is that strictures are a natural consequence of unchecked inflammation in the esophageal epithelium. And identification of this disease and having a high index of suspicion, and then getting adequate therapy to get this into remission are really paramount. And so I will let Dr. Lynch take over.
Next, we'll move on towards talking about patient presentation. And this section will talk mostly about adults. So symptoms of esophageal dysfunction in adults, largely dysphagia, food impaction, as well as heartburn. Patients also may present with regurgitation, vomiting, and chest pain. So when a patient has a clinical presentation suggestive of EoE, they undergo an upper endoscopy with biopsies, and if they have esophageal eosinophilia of at least 15 eosinophils per high power field, then they're thought to have eosinophilic esophagitis, assuming no other cause for these findings is identified. So going back to the symptoms of esophageal dysfunction, one that is relevant to many of the audience today is food impaction, which is often seen in the emergency room. So food impaction, let's talk numbers for a second. So we have 15, 50, and 1. So what is the 15%? Around 15% of food impactions that require emergent endoscopy. So that means that 85% of patients actually may spontaneously resolve their food impaction, but 15% of food impactions actually do require emergent endoscopy. And the stats show us that about half of these patients have EoE. And so we talked about how EoE is diagnosed, and so biopsies really should be taken during these endoscopies. So obviously the priority at that time is removing the food impaction. The one is less than 1% of patients actually will develop stasis changes, ulceration, leading to perforation, which is obviously what we fear, right? So that's the most dangerous complication of a food impaction that we certainly counsel our patients on, but it's very rare. So let's talk briefly about glucagon. This is frequently used for emergent food impaction as a smooth muscle relaxant. Success rates do vary. If you look in the literature, it's a wide range. So anywhere between 12 and 50% success rate. Higher doses have not been shown necessarily to be more effective in reducing LES pressure, and glucagon has been shown to be slightly less effective in patients with structural abnormalities. So thinking about the EoE patient with a more inflammatory phenotype versus a fibrotic phenotype. Studies, interestingly, do show that glucagon can shorten door to scope time, but that obviously may be confounded by other variables. Emergent endoscopy, timing is typically done within 24 hours, but if the patient is unable to manage their secretions, the endoscopy may be done sooner. So I know that we are worried about the esophagus, stasis, ulceration, and potential perforation, but really airway management is essential when you're considering a patient with a food impaction. Various techniques are used endoscopically for intervention, and so Rothnet is most commonly used as pictured here. That I can use, it's threaded through the port in the scope, and then we can use a net to actually remove pieces of food at a time. It's often very difficult to grasp the entire food bolus at once, but it can break up the food bolus into smaller pieces. Graspers are often used to break up a food bolus, and there has been described what I call a gentle push technique, where you can gently try to see if the food impaction can be pushed into the stomach. You have to be careful because if you haven't seen beyond the impaction, you don't know what's there. And then the pull technique can be used oftentimes in more proximal food impactions to remove the food out of the mouth. Biopsies are essential on an endoscopy. Most of these patients are untreated or potentially new diagnoses of EoE. And so in order to get them treated right away and get started on that pathway to avoid further food impactions, we need to be taking biopsies. Unfortunately, if you look at the stats, biopsies during emergent upper endoscopy for food impaction are not yet routinely performed in the majority of cases. Only about 20% of cases are, in about 20% of cases, are gastroenterologists routinely taking the endoscopic biopsies. Now, I understand why there could be concern, especially if there's an ulcerated site and there's concern for potential perforation or damage being done, but certainly biopsies should be taken throughout the proximal, mid, and distal esophagus and can be taken away from the site of the food impaction. People often ask about dilations. We perform these really on an as-needed basis if we see an obstructing stricture, and oftentimes they're not done during the emergent setting when there's a food impaction because there's the previously mentioned ulcerated changes and dilation may not be as safe, but in the outpatient setting, we routinely dilate strictures in patients with EoE. So next we'll talk a little bit about therapy in adults. So our current goal of therapy is histologic remission. Could this really be overly simplistic just to look at the eosinophils? There's really probably more spectrum of response looking at histology, but also patient symptoms, as well as endoscopy. I'm not sure how useful a treatment is if it's only treating the tissue, for example, and the patient's symptoms are persistent. And so there is the spectrum of response that has been proposed looking at non-response, some response, and then complete normalization. Additionally, the EoE Clinical Severity Index has been proposed recently, and that looks at different features of the patient's symptoms and presentation, as well as complications in their endoscopy, and a certain number of points is assigned depending on what their answer is. So for symptoms, if the patient has weekly symptoms, that would be 2 points. If they had a complication, such as a food impaction with an ER visit, that would be 2 points. And you can see the other points allotted as per below. If the total score is less than 1, that's inactive EoE, and 14 is moderate active. And if it's at least 15, that would be considered severe active EoE. So regarding therapies, there's diet as well as medication. Regarding diet, patients often say, why can't I go to an allergist and get tested for my food allergies and avoid those food groups? Well, looking at the data for that, this is largely limited to single-arm observational studies, and the studies are pretty heterogeneous. So looking at skin prick testing, serum-specific testing, atopic patch testing, or a combination of these things. So overall, diet limitation based on IgE-mediated testing is not currently recommended because it's not successful. What about the elemental diet? So elemental formulas are comprised of macronutrients broken down into their simplest forms. So monosaccharides, medium-chain triglycerides, and amino acids. So these are formulated to meet nutritional needs without any supplementation. There have been several studies of this, specifically in adults. The first study looking at 21 adults who were on the elemental diet for 4 weeks. 17 of these adults were able to adhere to the diet, and there was a very good histologic response rate of 71%. Second study looking at 29 adults over 4 weeks. Now these were adults who were consented for this study and were aware of the study. 3 of the adults abandoned the study on day 1. This is a very difficult diet. You're not permitted in these studies to supplement. This is supposed to meet all of your nutritional and caloric needs with these formulas. Throughout the study, 8 more adults had dietary noncompliance. And again, we're seeing a great histologic response rate, but after resuming a normal diet, the eosinophils increased very quickly in about 3 to 7 days. So overall, the elemental diet is efficacious, but it's difficult to maintain. So we commonly use an elimination diet. The most stringent is the 6-food elimination diet, which eliminates the 6 most common food groups all at the same time, including wheat, a dairy or cow's milk, eggs, nuts, soy, and seafood or shellfish. It's quite a process. Patients will undergo the 6-food elimination diet for at least 6 weeks, followed by an upper endoscopy with biopsies. If it is successful, they subsequently reintroduce 1 to 2 groups back at 6-week intervals, followed by an endoscopy each time. So over time, this is months and months of various elimination diets with a lot of endoscopies. Thus, there are many variations of the 6-food elimination diet, such as the 4-food, 2-food, and the 1-food diet. As expected, the efficacy of these diets does decrease as you eliminate less of the food groups. So overall, for dietary therapy for EoE, it's costly, it's time-consuming, there's numerous endoscopies, it's socially limiting as it's very difficult to go to a potluck and eat out when you have these very strict dietary needs, and it's difficult to maintain. But patients are very motivated to have a medication-free therapy for chronic disease. There aren't that many diseases that even have this option. So it really depends on the patient, but oftentimes this can be a successful option, though it can seem daunting. Let's move on towards medication therapies. So the current treatment options for EoE do include proton pump inhibitors as well as topical steroids. You can see a great table here by Dr. Mura's JAMA article in 2021 showing us that proton pump inhibitors of various types have a pooled histologic response rate of about 42%. Topical steroids, which include fluticasone as well as budesonide, borrowed from asthma, have a pooled response rate of about 65%. With proton pump inhibitors, what are the adverse effects? We all know there's numerous papers on, proposed possible AEs from proton pump inhibitors. We also know that from the retrospective studies, we're largely seeing overextrapolation of small effects effects that we're seeing from smaller populations that are sort of being overextrapolated to the general population. Looking more at prospective studies, we are largely comfortable using PPIs, but further data is pending. Regarding topical steroids for the adverse effects, Candida esophagitis has been reported in up to 16% of patients, though in clinical practice that might be a little bit lower because we're looking at studies that are actively doing endoscopies and assessing for adverse effects. Oral thrush has also been reported. PPIs are readily available with low cost. Topical steroids, like I mentioned, this is off-label use. Actually, technically, none of these are FDA approved for EoE, but the topical steroids are sort of being repurposed from asthma towards EoE. So fluticasone, as you know, is an inhaler for asthma. So patients will squirt and then swallow the medication. For budesonide, which comes in a vial, patients will sort of mix their own slurry. So they'll take the vial and pour the medication into a bathroom cup or a shot glass and then mix it with a thickener, such as artificial sweetener, sugar, or honey. If they don't like sweet things, they can even use thicket. Which topical steroid is better? Dellin et al. Looked at this in an RCT of 129 patients, looking at the budesonide slurry versus the fluticasone inhaler. So the budesonide is 1 milligram twice a day. The fluticasone inhaler is typically 880, so usually that's 4 puffs twice a day. And the post-treatment max number of eosinophils was comparable between the two groups. So overall, topical steroids are an effective primary therapeutic option, as are PPIs. There are emerging therapies for novel steroid formulations. Unfortunately, the budesonide suspension was not approved by the FDA in 2021. The fluticasone disintegrating tablet currently has ongoing studies. And the budesonide oral dispersible tablet is actually approved for use currently and is used widely in other countries. So what about Dupilumab, IL-4R alpha subunit receptor antagonist, which has been FDA approved for EoE? So a phase 3 study of Dupilumab, 300 milligrams weekly, every other week, or placebo, showed us that patients' dysphagia score, as well as peak eosinophil count, were significantly lower in the Dupilumab weekly group. And you can see the numbers here. On the left is histologic remission for parts A and B, and change in baseline dysphagia score in parts A and B here. So in brief, this is our first FDA-approved medication for EoE. Most of the patients in these studies did have other atopic conditions. So of course, when there's a new medication, people are going to ask, what were the adverse events? Looking at their table of adverse events as published by Dellin last year, there were no deaths and there were very few significant serious adverse events. Most of them were actually considered unrelated to the trial, except for one of systemic inflammatory response syndrome. And my understanding is that patient actually did resume the study successfully. The most common adverse events involve the injection site. So we're seeing injection site reaction, pain, redness, and swelling. And also nasopharyngitis was reported more commonly in the Dupilumab group over the placebo group, as well as headaches. So as you can tell from this pathway, we're sort of touching on the IL-4R alpha subunit receptor, but there's much more room for other biologics to be developed, and many of them that are undergoing current investigations are listed here. There's also non-biologics that are being proposed for EoE, and further studies are currently pending. So next we'll move on towards special considerations in pediatrics from Dr. Muir.
So by way of introduction, I'm just going to present 2 cases in order to illustrate the diversity of presentation in the pediatric group. So first, we have a 17-year-old male who comes to the ER with food stuck in his throat. He's unable to swallow his secretions and he's spitting into a basin. He's retching, but only saliva is coming up. He's able to speak and breathe comfortably. His past medical history includes allergic rhinitis, and he has normal growth, allergic shiners, and he's otherwise clear to auscultation. He undergoes an emergent endoscopy, and his biopsies reveal that he has 60 EOs per high power field, well above the 15 required for a diagnosis of EoE, and he has a normal stomach and duodenum. And then in comparison, we have a 5-year-old female who has a history of eczema, IgE-mediated food allergy to egg, peanut, as well as asthma and allergic rhinitis coming into her allergist for follow-up. So she had outgrown her milk IgE allergy 2 years ago and eats yogurt and ice cream regularly. And as an aside, her mother notes for the last 6 months, she's really had daily belly pain, reflux, and regurgitation. And her weight has trended down and plateaued a bit from the 50th percentile to the 30th percentile. And so she's referred to her GI doctor for evaluation. And she's initially started on a proton pump inhibitor and her constipation is addressed. However, her symptoms persist and she's diagnosed with eosinophilic esophagitis. And so what I think this shows is the large number of symptoms of EoE. So the symptoms of EoE in pediatrics include vomiting, feeding refusal, failure to thrive, and these are really the common symptoms in the younger children. The younger children have more of an inflammatory picture where they're vomiting. They're the kids that just won't eat. They need feeding therapy. And then in the older kids and the adolescents, they have a lot more dysphagia and food impactions. And abdominal pain and heartburn can kind of span the gamut. And so I think this illustrates that you have to have a high index of suspicion because a lot of these symptoms are very vague. There's a lot of children who come to the primary care office or to the GI outpatient clinic who have abdominal pain, heartburn. And so what are things that help you figure out who should be referred to GI, who should be scoped, especially with all of these diverse symptoms? And then to make matters even harder to figure out, patients with EoE develop coping mechanisms. And this is not unique to pediatrics. Adult patients develop these coping mechanisms as well, but it's something we have to consider because a lot of patients appear very well, but there are very subtle things. So I often ask parents, is your child the slowest eater in the family? Are they careful with eating? Is it chewing and chewing? Do they over lubricate food? If you sat down at a meal but didn't have a glass of water, would they be able to eat or could they not eat until they had a drink? Increased drinking, increased lubrication. We often have patients who say that they douse their chicken nuggets in tons and tons of ketchup, and that's really a lubrication method, not necessarily for taste. And then some patients just begin avoiding all tough foods. I will not eat steak because it feels too weird going down and things like that. So I think really diving into some of these symptoms to try to figure out what's going on has to be done. And it has to be done to try to figure out how your patients are doing. And so then in pediatrics, a lot of times we take a multidisciplinary approach. So we often involve both an allergist in order to get other atopic conditions under control, as well as a gastroenterologist and a nutritionist. In pediatrics, we often run into a situation where younger children are so limited in their diets that we have trouble removing foods. And so making sure that all of the micro and macronutrients are being taken care of is important, especially if diets are limited by both IgE and non-IgE allergies. There's often a role of a feeding therapist. However, we feel strongly that until patients are in histologic remission, meaning they have less than 15 eosinophils per high power field, they should not begin intensive feeding therapy programs because they will likely not be helpful at all and will lead to probably more family distress as well as child distress. And then lastly, we have psychologists, specific gastrointestinal psychologists who work with patients to help them cope not only with having a chronic disease, but also the stressors of not being able to eat what your friends are eating is a very stressful event that occurs in a lot of kids with atopic diseases. And also things like I have to take medicine every day, twice a day, and how do I cope with that? And how do I explain that to my friends? So these things can be very stressful, and having a multidisciplinary approach can sometimes help. And then the things we think about when we're thinking about our patients with EoE is that they tend to be very atopic. So when we look at our patients with EoE in the CHOP population at the Children's Hospital of Philadelphia, EoE patients are 6% of them have an IgE-mediated food allergy compared to the general population. A large portion, 30 to 60%, have asthma. 30 to 90% have allergic rhinitis, and 19 to 55% have atopic dermatitis. And so getting these atopic comorbidities under control is also important for the patient and how they're doing in general. And so the other thing to keep in mind is that in terms of allergic rhinitis, seasonal variations do exist. And what I mean by that is that while we don't think necessarily that pollen is the only cause of somebody's EoE, it can definitely exacerbate the EoE. For example, this patient, as you can see here on the right, has 60 eosinophils per high power field in May when scoped, and then in January has none. And then again, it goes up again in May and down again in January. And so evaluating the timing of each scope can be very important in order to understand, because you don't want to remove a food or increase a medication in a patient if pollen is playing a role. And sometimes being aggressive with a nasal corticosteroid is a good way to help eliminate some of this effect, but it's also important to remember the season you're performing these endoscopies in. And so then again, we often involve child life in our both at our endoscopies, and also think about the quality of life issues that our patients are having, because having many scopes in your childhood, we have some patients that have 20 scopes before they're 16. Those are stressful events for the family, and also the burdens of treatment. So the burdens of and both the financial burden as well as the social burdens. And so this is a list here at the bottom of AppFed and Cured are patient advocacy groups that help patients both at the time of diagnosis and as they're going through, and have support, and as well as other allergy groups. And so when we think about therapies, and Dr. Lynch went through the myriad of therapies, there's diet and there's drugs. We often offer choices. So what is the right therapy for one patient is not the right therapy for every patient. So important questions to ask is, what therapy are you going to be able to adhere to? If I have a patient in my office who is crying at the idea of not having pizza, then we shouldn't eliminate milk from her diet. And if the diet is already limited because the patient has multiple IgE-mediated allergies, it may not be feasible to limit it anymore. So thinking about how to offer choices and balance medical therapy and diet therapy, not one is right or wrong. And there are definitely some patients who do not want to have a medical therapy, and other patients that do not want to have a diet therapy, and neither one is right or wrong. And so the problem we always have in pediatrics is that we have to monitor this disease. And because of our coping mechanisms, it makes assessing the symptoms very difficult. But non-response rates are high. So depending on the therapy, the non-response rates can be 20 to 60%. And so we need to assess and the only way to assess for remission is to do a scope. So we end up in this cycle of scope and then fix the therapy. And if we change the therapy, we scope again. And it ends up being a bit of a vicious cycle. And one of the things we worry about is the burden of anesthesia in young kids. And so one of the things we've started doing, and this is data from the Children's Hospital of Colorado, and looked at the use of transnasal endoscopy. And what this involves is using a bronchoscope that's used commonly in ENT practices, and inserting a thin scope without any anesthesia into the nostril. And we often have patients wear virtual reality goggles, and we use a numbing spray in the nose and down the throat with like a lidocaine jelly. And it's remarkably successful. So there were 294 out of 300 attempts were successful. And then many of the patients enjoy this enough and want to do it again. It reduces the overall medical costs, and really there's very minimal side effects. In this study, 11 patients had epistaxis, 9 spit up, 8 vomited, 1 had nausea, 1 sneezed. But overall, it's extremely well tolerated. And I think the future is getting better for some non-invasive tests. And so over here on the right, the esophageal string test is being pioneered by the group in Colorado as a way of non-invasively or minimally invasively monitoring the esophagus. So the string is placed, the capsule is swallowed, the string unravels in the esophagus, and the string stays in place for an hour. And then after an hour, the string is removed, placed in a buffer, and shipped to the lab. And they can measure the chemicals and actually measure the eosinophil granule proteins on the string as a way of monitoring the EoE. Similarly, things like the sponge can actually kind of scrape up the esophagus and get tissue that can be fixed and looked at for histology. So, you know, as different treatments are tried, being able to use some of these non-invasive methodologies will be the future. And I think more and more research is looking towards at the use of looking at some of these molecular markers or possibly looking at organoids in order to more personalize therapy, you know, what therapy matches what type of inflammation. And so again, repeat endoscopy is an unfortunate necessity. And whatever the plan is, the EGD has to happen. And so, and patients can still have esophageal eosinophils without symptoms. And so the patient's symptoms are just not reliable enough. And so one downfall we often see is that because these patients are so atopic, if they need systemic steroids for any other reason, we have to make sure we delay the endoscopy or don't do it, because if systemic steroids are like kryptonite for eosinophils, and so you'll get a false negative response. And so what happened in our case reports? So our patient who had EoE was initially placed on high dose PPI. His scope improved visually, but was still abnormal, and he was placed on swallowed steroids, and that led to remission. And over time, he may consider Dupixent. And then in our female, five-year-old female who had 100 eosinophils per high power field while on a PPI, a variety of options were offered, but eventually she opted for dairy with resolution of symptoms and normalization of eosinophils. So just to wrap things up, EoE is a chronic immune-mediated allergic condition. It can affect people of all ages, and over 60% of patients have a comorbid atopic condition. Presenting symptoms in adults include heartburn, dysphagia, and impaction, and small children often have vomiting and failure to thrive. 50% of patients with food impactions have EoE. Medical therapy includes proton pump inhibitors, topical swallowed steroids, and Dupilumab. Elimination diets are the most common form of dietary therapy in adults, and long-term therapy is recommended.
Awesome. Thank you, Amanda. It's always a pleasure to present with you. It looks like we have a couple of questions in the chat. So I'm going to start with the first one regarding endoscopies. So for adult patients, the question is, how often do patients need endoscopies? You know, it is tricky because I tell patients initially when they come to me, you're going to see me a lot, you'll have multiple endoscopies, and then once we figure out how to control your disease, or if they need serial dilations to get a stricture dilated, then that will be done, and I'll see you in a year in the office to check in how you're doing and see how your symptoms are. I'm not sure if the question, so that's a lot of endoscopies in the beginning, because every time you change a therapy, we do an endoscopy to ensure histologic remission. Every time patients reintroduce on an elimination diet, we do an endoscopy to ensure histologic remission, because symptoms do not correlate perfectly with histology. Otherwise, we definitely wouldn't do them. It looks like it's another question maybe for Dr. Muir about children. I don't know if you want me to read it to you, Amanda, or if you can see it in the chat.
Go ahead and read it to me.
Sure. So what is the threshold for you, Dr. Muir, on when to do an endoscopy in a child not gaining weight appropriately?
So that's an excellent question. And I think it's one of those things that we struggle with frequently as pediatric gastroenterologists, because we know that the yield of doing an endoscopy on a patient with failure to thrive is low. I tend to use two things to help me lean one way or another. So first and foremost is, are there comorbid atopic conditions? So I do think that if a patient has pretty bad asthma, really bad eczema, that would probably sway me more to scope in order to diagnose EoE and get that patient under control. I think the other thing I think about is if we're moving in a direction where feeding therapy is required, figuring out whether the patient has EoE prior to doing any feeding therapy is paramount, partially because feeding therapy is very intense. It is very emotional for families. It's kind of rough. And to undergo that type of intensive therapy when there's inflammation in the esophagus, and every time the child eats, they're going to have a negative stimulus, it's just not going to work, because feeding therapy is based on having a positive reinforcement. So I think those are the two things that end up helping sway me. If there's a lot of feeding refusal, and atopic conditions are the things that really end up swaying me the most.
Awesome, thank you. I can take the next question. The question states, is there any role for video capsule endoscopy in EoE patients requiring frequent endoscopies or flares? You know, right now we're not using the small bowel video capsule imaging, but I think the root of this question is a great question and an area under intense research right now. So thinking about the cytology sponge, thinking about pill on a string, so even transnasal endoscopy, but unsedated endoscopy, but essentially more minimally invasive ways to assess for EoE are certainly being investigated. The cytology sponge has been investigated as well to look at patients with EoE as they reintroduce foods. So that's a great population to have a sort of a less invasive option that also may not be therapeutic. For instance, none of these options where the patient swallows something and then we take a sample by essentially pulling a string out of their mouth, none of them can dilate. And so in a patient without known strictures who's simply reintroducing food groups, it's certainly, you know, I hope that in the future we have a non-invasive method of monitoring their eosinophils without constantly having to do these endoscopies. But no, at this time, there's not anything well established that is being used. And a question for Dr. Muir. It says, is there a link between asthma and EoE, and is this common?
So that is a great question. So the short answer is yes, there is a link between, and by link, more patients who have there are more patients that have with EoE that have asthma than in the general population. So it does seem to be a common comorbidity that occurs in EoE patients, along with eczema and along with IgE-mediated food allergies. So we really do see this constellation of atopic disease in our EoE patients.
Awesome. And someone had asked, I'm not sure if this is directed towards adults or kids, so maybe we could both answer it, but it said, would you treat with a PPI and fluticasone and a restrictive diet? Would a dietary restriction be done alone? So this is a great question. Typically, I start with the least that we need to do. So when I have a new patient with EoE, I counsel them on the treatment options, and usually it's medication or diet. The beauty of the medications are you can be on a normal diet, and the beauty of the diet, of course, is that you're not on medications. Typically, patients will choose PPI therapy first. So I would do PPI alone. This is, again, most commonly, but every patient is different. And then I would do that for at least 12 weeks and do an upper endoscopy with biopsy and assess the patient's symptoms to see if they're in symptomatic and histologic remission. At that point, if the eosinophils are still elevated or the patient is not having symptomatic relief, we could escalate to another medication option or switch over to diet. And in either case, it is debatable. Some people actually do keep the patient on a PPI for the 6-food elimination diet or another elimination diet, and some providers don't. I usually will counsel the patient on this and they can decide. I found that many patients on an elimination diet are choosing that to avoid medication, so they prefer to be off of the PPI if it did not work for histologic remission. But typically, we don't do what has sometimes been deemed triple therapy, right, where we throw everything at the patient. Typically, we try to do medication or diet. There are rare cases where I've had to do combination therapy. And these are in strictured refractory EoE patients who have not responded to PPI, to steroids, to higher doses of topical steroids, or an elimination diet, or were unable to do a full 6-food elimination diet. So I've had to do combinations of therapy. I've had probably less than 5 patients who I've had to do that on. And then lastly, there are some patients who have EoE, but they also have GERD, especially with our adult patients. So they may already be on a low-dose PPI for heartburn and liquid regurgitation of acid. And then separately for the EoE, they may be on Glucagon, Dupilumab, or a restrictive diet. I don't know, Amanda, if you want to comment on combination therapy in children.
No, Chrissy, you knocked that one out of the park. I agree with you. I think it ends up being the type of, when we end up getting to the point where there's multiple therapies, it's in the more refractory cases. It will be interesting to see as more and more patients are, now we have another medicine to try with the recent FDA approval of Dupilumab. So I think we'll be able to, in some of our refractory patients who we've had on these combinations of therapies, whether Dupilumab will be an option for them. I think that will be an interesting thing to find out in the future.
Me too. Yeah, for sure. We have time for a couple more questions. Oh, go ahead.
Oh, I was going to say there is a question about Dupilumab since we were just talking about it. It says, does Dupilumab help for any food allergies besides suppressing eosinophils? So I think this is a little bit of a question that's a little bit to be determined, but Dupilumab acts by blocking IL-4 and IL-13 signaling, which eosinophils are downstream of. So by inhibiting those cytokines, you're really promoting healing in the epithelium as well as decreased eosinophil chemotaxis. And so I think that that's why Dupilumab has been helpful for eczema, asthma, chronic sinusitis, and now also eosinophilic esophagitis. Not necessarily, I don't think there's any evidence to support its role in IgE-mediated food allergies, but I do think it helps this constellation of allergic conditions, especially allergic conditions that affect the epithelium.
Awesome. Another question that's come up, is dietary therapy and or pharmacologic therapy needed for a lifetime? This is a really good question because the majority of patients, often the ones who present with food impaction, will feel much better after a dilation and 12 weeks of a PPI. But the answer is yes. We worry that if patients get off of therapy and they have chronic inflammation, that could ultimately lead to downstream effects leading to fibrosis down the line. So what I tell patients is you need to be on something, but you don't need to be on the same thing. EoE is an area that is blossoming with tons of research, looking not only into discovering more about the pathophysiology, but also targets for therapy. So I typically, once patients are in remission, I'll have them check in with me annually at the least to assess what's new, what's different, what's going on. I mean, if this talk was being given a year ago, we didn't even have an FDA-approved medication for EoE. Dupilumab was approved in May of 2022. So I do tell patients they need to be on something, but it doesn't need to be the same thing. I also have some interesting, unique cases where Patients change therapies when their lives change. So the classic example is the college kid who comes in and they come in with their parent and you're talking to them about treatment options. And when you're talking about the elimination diet, they look terrified and the parent is nodding their head. So you know that that's extremely challenging to do in that setting, especially with so little control over what they eat, eating food cooked in the school cafeteria. So typically those patients will do medication, but once they graduate, they may choose or sometimes be pressured into changing more towards an elimination diet. And so that's one life change that often happens. I also have patients who are largely on the diet and sometimes they take breaks, especially when they travel for long periods of time and maybe they'll go on a medication. That's a really unique situation, but it's just an example how the therapy can be fluid and it really needs to be personalized medicine for what fits in with the patient, because we do want them to be on something long term. If you look at studies in patients in deep remission, so symptomatic, endoscopic, histologic remission, and you stop their therapy. So in the one study I'm thinking of, they stop their steroids. Over time, all of the patients fall out of remission. And so we do worry that patients will, develop recurrent inflammation and ultimately lead to fibrosis.
If we have time for another question, I think that there's a question about using Fasenra, and that is one of the pathways we talked about a little bit. It's Fasenra is benralizumab, so it's an anti-IL-5 antibody. Unfortunately, there's no FDA approved anti-IL-5 drug that has been approved for the use of EoE. So I think if you have a patient, it is FDA approved for other atopic diseases like asthma. So if you have a patient who has asthma who's on Fasenra and you wanted to see if that controlled their eosinophilic esophagitis as well, I think you'd have to monitor with an endoscopy to see if it's working and see if it helps, because I think that's a little bit more challenging because it's uncertain if that how that medicine would work. And there haven't, I think the randomized control trials haven't, the results haven't been published yet.
Awesome. There's another question that's come in. What advice do you have for primary care providers in terms of referring patients to GI? I think it's really tricky because primary care providers really, own their patients and want to sort of, do everything that they can. But as you've seen in the slides, the prevalence and incidence of EoE is increasing significantly. And oftentimes these patients actually have symptoms since they're children and they're told they're eating too fast, they need to slow down, they need to use more liquids, and that it's normal. And the problem is then they think that it's normal and they become adults who have difficulty eating in social settings, are constantly snacking because they're unable to finish their meals. And I think that as primary care providers, it's really important to make sure that any patient, even without atopic conditions, to consider referring to GI for the endoscopy. With atopic conditions, certainly. And then the most common thing we see in a patient who presents with these symptoms that's not EoE is often a peptic stricture, if they're truly having, recurrent food impaction. And so either way, they might need to be dilated. So I think the threshold to refer is low. If they're having atypical symptoms like regurgitation and with some heartburn, but maybe mostly liquid regurgitation, that can be tricky because you're wondering, oh, do they have GERD or do they have EoE? So, a PPI trial might be reasonable at that time. But in the classic patient with, true solid food dysphagia, I do think that it's appropriate to refer early. All right, and I think we have time for one more question. I'm going to take it, if that's okay, Amanda.
Yes.
It says, after remission on a particular therapy, does EoE recur? Is there any role for surveillance endoscopies in these patients? So that's a really good question, and I don't feel like we have the perfect answer for that timeline. But yes, we do see that there can be eosinophilic inflammation in patients on a therapy that has worked for them. So over time, we see the response to that same therapy wane, and that's concerning. So that's why I do take a very detailed history when I see my EoE patients. I always try to ask them what sort of foods they're eating and if they're able to eat what they want to eat. And then I actually write down what they eat and I compare it the next year to see if they're still able to eat whole meats and melon fruits and bagels in Philadelphia, soft pretzels, but like those dense carbs that are harder to eat and those whole meats that are harder to eat. Is there a role for surveillance endoscopies? That is not in the current guidelines. If you look at expert opinion, there can be arguments for anywhere between a surveillance endoscopy, anywhere between 1 year, 2 years, 3 years, 5 years. We really don't have the perfect data for that, but I think it's really important that patients are making sure that they check in, first of all, to make sure they're compliant with their meds, they're comfortable taking those meds long term, make sure they're not ready to change from med to diet or diet to med, and then assess if they do need an endoscopy.
Well, thank you very much, Dr. Lynch and Dr. Muir, for your excellent and informative presentation. And thank you so much to everyone who was able to join us for the presentation. We hope you have a few key takeaways that you can apply to your practice. For those questions that we could not address, we will continue the conversation on the ACG Circle. Thank you again and have a great evening.